The randomized trial model is designed to address research questions that have yes or no answers. In other words, binary questions. Sometimes research questions in real life also have yes or no answers, but such situations are in a minority. More commonly, we have to adapt the research question we are interested in to make it into a yes or no question in order to allow use of the randomized trial model. As an example, consider the question, what is the effect of aspirin on the risk of having a heart attack? This question potentially has a complex answer. Aspirin reduces the risk of heart attack by a quantifiable amount, and this varies depending on the risk factors and clinical condition of an individual patient. In order to conduct a randomized trial, we have to derive from this complex situation a yes or no question. It is likely to be of the form, in this group of patients, does aspirin reduce the incidence of heart attack by more than 10%? This process of casting a research issue as a yes or no question is common to virtually all randomized trials, and it has significant implications for how research topics are tackled. Trials do give more information than a simple yes or no answer. A large amount of data is generated that allows secondary issues to be addressed, like how much benefit a drug has and in whom. But the primary research question, and the one that is answered most reliably, is the yes or no one. Supplementary data may be useful, but only as qualifying information of the primary trial result, not as information that stands independent of it. Some large trials are designed with enough power to answer several yes or no questions. The carotid endarterectomy trials that I will come to are examples, but these are in effect multiple simultaneous trials that still have a basic binary design. In a favourable situation, the question we are interested in can be approximated closely by a yes or no question. In the case of aspirin, the question is simply, should this patient be prescribed aspirin to reduce their risk of heart attack? Details such as the amount by which the risk is reduced are of lesser importance. It is reasonable to pick the threshold at which we would consider prescribing aspirin based on costs, risks and convenience. Then conduct a trial that asks whether aspirin reduces the heart attack rate by more than this threshold. Several large trials have been done on this question and show that aspirin does reduce the risk. Trials aimed at testing drugs often have this advantage of fairly close approximation between the trial's binary question and the clinically important issue. The situation is not so simple when testing treatments that are more dangerous than aspirin with less clear advantages. Examples are the many cancer chemotherapeutic drugs or treatments that are not drugs. In these cases, the issue of interest may only be crudely approximated by a yes or no question. Consider, for example, the condition of low back pain or lumbago, a common and disabling condition that is associated with arthritis of the spine. It is notoriously difficult to treat. Literally hundreds of treatments are available, but the evidence that any of them has a lasting benefit is slim indeed. Research in the area has been impaired because the condition is a complex one with multiple contributing factors. We may want to research the effects of a particular treatment, but approximating the question, what is the effect of this treatment on lumbar back pain, with a yes or no question such as, does this treatment improve lumbar back pain by more than 10%, is so crude as to be of minimal use. One operation that is used for lumbar back pain is spinal fusion. In this operation, screws are driven into adjacent vertebral bodies and connected together with a system of rods to fix them in relation to each other. Additional measures are taken to encourage the two vertebral bodies to join together into one bone. The idea behind this operation is that the pain comes from joints, not bones. If the joint movement is eliminated by fusing bones together, the joint pain should stop. The problem is that the operation is a major undertaking with considerable risk. If we want to find out if this operation is effective in relieving lumbar pain, we plan a randomized trial. We have to come up with a yes or no binary research question that is meaningful when applied to patients after the trial has been done and achieves equipoise, so is ethical and feasible to address. Lumbar fusion is quite widely done. Many spinal surgeons have great experience with the procedure and the results that it gives, and have a good idea of who to use it on. Opinions do differ, but all surgeons agree there are some patients with back pain who should not have the operation. Patients with arthritis throughout the lumbar spine are one such group. There are other groups of patients that surgeons agree should have the operation. Patients with a slip of one vertebra on another, called spondylolisthesis, are such a group. In both of these groups, equipoise does not exist, so they are excluded from trials. For other patients with one or two arthritic joints and no slip, surgeons are often in equipoise, so several trials have been conducted on this group. The results of these trials were similar to each other. Around 20% of cases crossed over from one treatment to the other. The intention to treat analysis showed some improvement of back pain with surgery, but the effects seemed minimal. Few surgeons changed their practice in the light of these results. Outside of the subject of randomized trials, binary models are of course not the only ones in use. If we classify models according to the nature of their output variables, trials are binary because their output is either yes or no. Other kinds of variables are categorical, ordinal categorical, and continuous. Categorical variables are things like types of rock, animals, or treatment. We can place such things in categories without implying any specific relationship between the categories. Ordinal categorical variables are those in which the categories are strictly ranked. The number of children in a family is an ordinal categorical variable. The categories are 0, 1, 2, and so on, and there is a strict relationship between them. 2 is less than 3 and more than 1. Continuous variables are those that can take any value over a particular range. They are the most useful and allow for the most powerful statistics. Mean blood pressure is an example. Others are age, weight, body mass index, and blood sodium concentration. The number of children in a family is not continuous because you can't have half a child or any other fraction of one. Any of these kinds of variables can be approximated by binary numbers. This means that research questions of interest that cannot be reasonably addressed with a single binary trial can be approximated with multiple binary trials. The effect of approximating a question about a continuous variable with multiple trials that yield binary results can be seen in the case of surgery for carotid stenosis. The main blood supply to the brain arrives via the left and right internal carotid arteries. These arteries commonly become affected by atheromatous disease, the same process that causes heart attacks. The atheroma narrows the carotid arteries and makes the lining irregular and prone to provoking the formation of small clots. These small clots are liable to detach from the atheromatous plaques and travel in the bloodstream, where they lodge in the small arteries that feed the brain or eyes. This mechanism is one of several causes of stroke and mini-stroke. When someone has a stroke or signs of a mini-stroke, doctors seek to find out the cause. One of the tests involves scanning the internal carotid arteries to see if they are narrow. If they are, it is possible to remove the narrowing with an operation called a carotid endarterectomy. While this operation may prevent strokes in the future, it carries a small risk of causing a stroke itself. This situation led to the research question, which patients, if any, benefit from endarterectomy, and specifically how high should the risk of stroke be to justify the risks of surgery. A number of randomized trials have been done on this subject, and collectively they largely answer the question. The North American Symptomatic Carotid Endarterectomy or NASCET trial ran from 1987 to 1996 and recruited 2,226 patients. The European Carotid Surgery trial, or ECST, ran from 1981 to 1994 and recruited 3,024 patients. The two trials were large enough to show the effect of surgery in several subgroups, and they had similar findings. Patients with more than 50% stenosis benefited, and those with more than 90% stenosis benefited the most. Patients with stenosis of 30 to 50% did not show any difference, and those with less than 30% showed a detrimental effect. The feasibility of conducting these large trials is unusual in surgery and was down to several factors. Stroke is managed by physicians who have typically been involved with several trials of medications. The effects of surgery are not seen immediately because it takes some years before the operative risks are balanced by the stroke prevention effect, so individual surgeons do not have a clear idea of benefits from their own experience, making them more inclined towards equipoise. The carotid endarterectomy situation illustrates a more general principle about maladies that affect individuals to different extents and treatments that carry their own risks. The argument in favour of such a treatment, technically known as the indication for the treatment, cannot adequately be modelled as a binary variable, but it can adequately be modelled as a continuous variable. If the indication for a treatment is modelled as a continuous variable, in general it can range from a negative value through 0 to positive. This equates to patients in whom the treatment is clearly not indicated at the negative end of the range of the continuous variable, to patients where it is clearly indicated at the positive end. I will refer to the range of this variable as the spectrum of indication, and to the variable itself as an index of indication. The trials on carotid endarterectomy used the percentage of stenosis as the index of indication and gave multiple binary results that approximated this index as an ordinal categorical variable. The categories were greater than 90%, 50 to 90%, 30 to 50%, and under 30%. The indication for surgery is a function of the index, being strongest in the over 90% category, persuasive in the 50 to 90% category, in equipoise in the 30 to 50% category, and negative in the under 30%. The raw data generated by the trial can be used to approximate indications as functions of the continuous variable percentage stenosis. The trials were not primarily designed to do this, but they demonstrate the existence of this function, which is a central part of the Null Seeking trial.